All right, well, welcome everybody. My name is Corey Luebbering, and I'm the PBR and coordinator at DO-Touch.NET. Thank you for joining us for this month's episode of Let's Talk About OMM Research. Before we begin, let's take a moment for the housekeeping rules of the webinar. First off, please feel free to introduce yourself in the chat and tell us where you are from. We also invite everyone to turn on their cameras if you would like, so we can be united as an OMM research community. Second, if you're having technical issues during the webinar, please put a message in the chat. Third, if you have questions or comments during the presentation, please feel free to type them into the chat and address each other's questions and comments there as well. We will have time for discussion and questions at the end of the presentation. And lastly, please keep in mind that this webinar is being recorded and will be placed on the DO-Touch.NET YouTube channel. But today is our Let's Talk About OMM Research Journal Club on the article entitled International Overview of Somatic Dysfunction Assessment and Treatment in Osteopathic Research, a Scoping Review, with Dr. Francois Lalonde. Dr. Lalonde has a doctorate in exercise physiology, a diploma in osteopathy from Canada, and a bachelor's degree in kinesiology. He is currently a professor in the Department of Physical Activity Sciences at the University of Quebec, Montreal. Francois was instrumental in creation of the first osteopathic university programs in Quebec. So help us welcome Dr. Lalonde.
Well, that's a great introduction, so thanks a lot. So I'm going to try to share my screen first. So let me know if it's okay with you. All right. So do you see my screen well?
Yes.
All right, great. Well, it's really a pleasure to be here with you today. So first of all, sorry if my English is not that good. So as you may hear, I have like a little bit of a French accent. So I'm from Canada. And just to give you a background of the osteopathy in Canada, there's a legislation that has a full medical recognition for doctor of osteopathic medicine that come from the United States, but most of the practice in Canada is osteopathic manipulative practitioner, as I do. So just to get a glance in the province of Quebec, there's less than 5 DOs in the medical college, and there's more than 3,000 osteopathic manipulative practitioners. So that gives you a sense of what to come. So, I found that this article, if we go into an international perspective, what we do with somatic dysfunction in research, well, I mean, that's a cornerstone. So we just, build our first osteopathic program here in Quebec. And one of the cornerstone is how do we perform research in osteopathy. So I guess somatic dysfunction is part of the equation over here. So that's why this article for me is really important. And I'm glad to share my thoughts on this with you today. But unfortunately, my analysis will go quickly. I won't play like the reviewer of that article, but I'll go to the main point and I'll try to go on a broader discussion. And before we start, I just want to make sure that MDPI journals, I know that sometimes there may be some controversy that they are maybe a predatory journal. So I just want to be aware of that, but still the article can be found on PubMed. So let's start. So what is somatic dysfunction first? So this was a study done in Italy. And I mean, that's a question that every osteopathic practitioner in the world asked themselves. So they asked the question to 11 osteopathic, and they gave an answer, and as we can see, some of them, they come with a different answer. So it's not always quite well defined. And if we put that exercise with some student of mine, then we still have some discrepancy when we talk about somatic dysfunction. But as we know, what seems to be more common, it's that somatic dysfunction is part of the osteopathic profession as an identity and a profession. So this is why research with somatic dysfunction should be a bit clearer, to better define what it is and what it is not. So maybe before we go to the article, again, a quick evolution of the concept. So first, there was that regional approach. Back then, it was more like osteopathic lesion that evolved into the concept of an altered function associated with structural change. I just want to make a little parenthesis. At some place in the world, the use of osteopathic lesion or osteopathic dysfunction is often used even today instead of somatic dysfunction. So sometimes the word can be interchangeable depending on where you are in the world. So and it's very like a biomechanical approach, so that was one of the first definition. Then later on, the somatic dysfunction was considered more as a result of vascular change related to connective tissue and inflammation. And later on, so we'll continue. So somatic dysfunction was more into like a somatovisceral reflex as the basis of existence of facilitated area of the spine. And in 68, if I'm not mistaken, maybe correct me if I'm wrong for that, osteopathic lesion term was replaced by the term of somatic dysfunction. So later on in 1976, there was more like a nociceptive model of the somatic dysfunction. And there was with that, a high consideration of vertebral dysfunction and related of the neural process consequent to the injury. So the concept still evolves. So in 2015, the concept is more considered as to be linked in with fascial network, with the body regulation process, so that, such as a biological and a psychological adaptation. So now we see a little bit more of that biopsychosocial model that may come into the notion of somatic dysfunction. Then the community has begun to debate the shift from a more, biomechanical model shift to a psychoneuroendocrino-immunological pathway, and to obtain a more patient-centered concept of the somatic dysfunction. So just as we start, now, when we'll go to the article, depending on all the article and the science that was published in the literature, depending on the era that those studies were done, maybe the definition of the somatic dysfunction was not quite the same even through time. So, I mean, that's a good thing to consider when we want to use or study the concept of somatic dysfunction. And as an example, here in Quebec, people have really hard time to use the word somatic dysfunction. Most of people in Quebec, they're more accustomed of using, still today, the term osteopathic lesion. And one of the competency framework that from Osteopathy Quebec, they call it osteopathic somatic dysfunction. So they all combine the words together. So that is at some point a little bit confusing for the world within our community and when we want to do research. So now we're going to go through that paper. So that was the international overview. So it's a scoping review. It's not a systematic review. The aim was to map the existing literature and the role of, and the use of somatic dysfunction in osteopathic research. Now, other goal is what can be gleaned from the current literature about the use of somatic dysfunction in osteopathic research, and how it eventually considered an approach in osteopathic trial. So the main question is how the term, let's say, osteopathic dysfunction can be correctly used with the same language in all those trials if we want this to pursue as a professional identity. So the methodology of the paper, they did a search on most of the research motor. So they had PubMed, Medline, Cochrane, Embase, Pedro Scopus. They did not include osteomet.dr. And they say that they also conducted a great literature research via Google Scholar and Osteopathic Research Web, but they didn't give any more details about those websites. And osteopathic approaches that were considered, they consider, this is in the methodology, but we'll see later that it's going to be broader than that. But they had considered myofascial release, high velocity, low amplitude trash technique, muscle energy, craniosacral treatment. And this may be confusing from people abroad. You know, the osteopathic cranial medicine approach versus the craniosacral therapy. That's some are maybe confused in some part of the world, but still, that's what they've done in their methodology. And they also put visceral manipulation. Again, they utilized some standardized OMT protocol, semi-standardized, or black box intervention. They exclude all the studies that considered as a single osteopathic technique, or that they did not specify a particular osteopathic approach. So they excluded like manual therapy or chiropractic therapy. So, well, if we analyze this, if a chiro does HVLA, it's not considered as an OMT. So, you know, that's the kind of thing that we may think, or a physical therapist that perform, let's say, muscle energy or myofascial release. So they didn't consider that. So that may be let's say a flaw in the study, because at some point it was the technique itself, but it was not identified as OMM or OMT. Also, what they did in their, sorry, I'm just going to move my screen over there, is that the place of the somatic dysfunction in the assessment, the role of somatic dysfunction, the role of treatment, and the time frame of treatment. So again, there's other OMT. So if we go into the Educational Council of Osteopathic Principle, I mean, they're not all listed over there. And some people that work outside the United States, maybe they include other technique into an osteopathic approach that is not part of the classical ECOP consideration. So no keywords also in the study, and we don't know also the study type, so they don't have any inclusion or exclusion criteria for what they include as a kind of studies, and there is no quality assessment. Again, it's normal, it's a scoping review, it's not a systematic review, but still we can have the question over there. So over there we got their database recording. So they included 280 study. So that's roughly a lot of participants. The age was around 38 years old, plus minus 22 years old as for patients. So there was a lot of paper over there. So we'll go to the detail of that. But the authors did not mention what they found in the gray literature. They have put it in the methodology, but we don't know what article or what they found with the gray literature. So that's a remaining question on that paper. Now, for the results. Oops, sorry, I'm gonna go over there. Just gonna, sorry. It's my screen over there. All right. So 86% of the inclusive studies were carried out on symptomatic participants. So what we may understand from that is they had some form of pain, pathology, or so. So there was a minority who was asymptomatic. There were 166 clinical trials, both randomized and non-randomized. And we don't know how many were randomized versus not randomized. So the author didn't point out those aspects. There were 80 case reports, 39 case series, cohort, and case control studies. Now, OMT was performed by professional osteopath in 156 studies, by osteopathic students in 19 studies, and others, physical therapists in 15 studies. So this is what I've mentioned earlier, let's say if HVLA is performed by a physical therapist or a chiropractor, why it wasn't considered first, but now they consider that in their results. So this is quite of a mismatch from maybe the methodology. And again, what I found interesting in those results is that all of those studies, it seems like it's important for researchers that to declare that OMM or OMT were performed by an osteopath. So is it a question of experience? Is it a reason to maybe say that the quality is good? So this is not mentioned. But again, we may ask a question from a more scientific perspective. What does the osteopath performing an OMT different from a chiropractor or a physical therapist? So is it like the touch? But it brings a lot of question, and into that we don't have an answer because most of those papers they don't go into that detail. But still, when people read that, well, we may have a question about this. And 33% of the studies reported unclear or no information about the person who performed the OMT. So that's was for this. Next slide. All right. So this is the distribution of the use of somatic dysfunction that was clearly identified in the country that performed the studies. So as you can see, in the blue, so this is when it's unclear. The green part is when somatic dysfunction was considered in the study, and not it's in the red. So as we know, the United States is the more the best provider on OMMT and OMM research. And again, when we look at those the studies that goes from the United States, it seems like half and half. Sometimes they refer to somatic dysfunctions, and sometimes they don't, and sometimes it's unclear. The other country that seems to produce a little bit more research is Italy. I don't know if because the authors were Italian, that they seems to look a little bit more representative than the other country. But still, again, we see that there's sometimes they do consider somatic dysfunction, sometimes they don't, and sometimes is not clear. So we got that distribution mainly that come from across the world. Now, sorry, I'm just gonna try. Okay, so sorry, I'm just gonna. I'm having a hard time with my screen over here. I'm just going to put that down. All right. So 95%, 5 studies did not report any information about the use of somatic dysfunction. And in 20 studies, this information was unclear. Out of 214 studies, the TART criteria was not used to identify somatic dysfunction. Only 60% of the include studies had adopted the TART criteria. 4.2 used other method, and finally 5% that were unclear information about the parameter used to find somatic dysfunction. Also, in the result, we see that somatic dysfunction were considered more, locally, and in 56 study, so 20%, it's more like the global approach or a segmental approach with the somatic dysfunction. And sometimes both local regional or segmental approach was used in 6 studies, so it's around 2%, which is not a lot. And 55 studies, there was no clear information about either it was a regional or more global approach. Now, this result to me is a little bit surprising because as the first point to see, 95 studies did not report any information about the use of somatic dysfunction, but still in 155 studies, when it came to the treatment, it was declared that it was based on what they found as somatic dysfunction. Now, the choice of treatment or OMT to treat those somatic dysfunction, as we can see, most of the studies used myofascial technique or myofascial release, muscle energy, and the other more into HVLAs, articular or cranial, or even balanced ligamentous tension. So that was the most of the technique that were used to assess somatic dysfunction. But again, was it specific? Was it larger? We don't have the answer, because sometimes when we look at those studies, some protocol that said in the yes box circle over here, those who use somatic dysfunction to orient their use of OMT, 45% were black box. So that means that they just found somatic dysfunction on a patient and treated what they found, but we don't know what they actually did. Okay, so I mean that's probably more ecological in a sense that that's the way most people work into their clinic. But again, in science, it's hard to know what was already done. So there was also 35% of semi-standard protocol. So they, in those type of study, probably they have like a standard protocol to use, and sometimes they added specific treatment for what they found in somatic dysfunction. And for the use of somatic dysfunction, there was also 20% that were used only a standard approach. So when we use that, the problem in research is that if we only have a standard protocol and we use it and there's no real somatic dysfunction to treat, then again, is the protocol doing its job? So that's a question that we may ask. And for studies that did not report the use of somatic dysfunction, the majority, so 68%, had more of a standard protocol, which for me is kind of a good, but not a good thing, but it's more relevant, because if they didn't know what was the somatic dysfunction, then it's okay to go with a standard protocol and see whatever happens with the outcome of the study. So that was the distribution. Again, in the results, so the 65 article evaluated the effect of a single OMT session, 101 used 2 to 5 OMT session, 79 studies used more than 6 sessions into their study. The frequency of OMT was mostly around 1 treatment per week, and in 57 studies, it was less than 1 treatment per week. And we see that there was 2 treatment per week in 31 studies and more than 4 treatment in 19 studies. And around 50 studies did not report any information about the frequency of the session or report unclear information. So regarding each session duration, 61 study using OMT lasted maybe around 30 minutes. 97 lasted 30 minutes or more, and 87 did not report any information about the OMT session, and 43 study reported unclear information about the duration of the treatment. So that gives us a bit of a good portrait of how OMT is used in research. Again, there's some some flaw into that review, but again, it's interesting to see all those results to maybe better think what and how we can integrate better the concept of somatic dysfunction into studies. Oh yeah, and one last result is that they had a control group, and other studies did not have any follow-up control as well. So one of the other critique about this article is there are no summary table, and there's some lack of reference when they do some claims. So sometimes it's hard to really understand what the authors meant or what they point out. So now I'm going to go out of the article just to a bit of a reflection. So that was, one of the study that was published in the JAMA. It was about the effect of sham therapy versus OMT for non-specific low back pain. That was a study that was performed in France. So what's interesting is that it's in a great journal, and my point over there is that when they come to the methodology of OMT, what they did is a standardized protocol. So that's the technique that they use into their study, and that when we go into their supplementary material, we do understand that they were seeking for somatic dysfunction as well. So now we get confronted into a protocol that use standardized treatment, and also they did a specific assessment with their patient. Again, there's no soft tissue technique in that, no reference to the STOPS trial over there. So again, since it's about low back pain, we can go to the STOPS trial that they refer to the a preference technique with the type of low back pains. So at some point, maybe sometime HVLE is better than the other for more acute or problem like this. So again, there's a lot of confusion with their patient and how they use OMT with somatic dysfunction. And also, I do understand that they use that kind of protocol to respect a certain form of globality. And again, so there's remote region, there's visceral, MSK, and cranial. So, and again, each time we bring up cranial, there's always some criticism that can be done about vitalism. So that's art, in science to really measure as well. And again, it's always based on anatomical probabilism. So again, that's also another concern sometimes in research. So versus global health or MSK risk factor like bone density, muscle mass, VO2 max strain, and blood tests. So I mean, that's more of a holistic approach that can be fit in a better global. So if we go back to that STOPS trial, so as they can see, some for low back pain, they designed that manipulation or mobilization responds better to HVLE. There's, a direct specific exercise. So what kind of OMT could be preferred over there? There's stabilization protocol and persistent pain. Again, I mean, in that point, not only that the somatic dysfunction will lead to the choice of OMT, but it will also be the better choice of treatment for a specific health problem. So again, so if we take the global discussion on somatic dysfunction, like Gary Fryer said in his last presentation, there's no clear physiopathology, there's no orbital sensitivity, specificity, or likelihood ratio for specific MSK conditions that are associated with somatic dysfunction. There's also the fact that sometimes we may be to a point to avoid nocebo or undesirable effect of using the term of somatic dysfunction in the treatment. So I'm just going to look at my time. I'm good. Okay. So again, so if we include the somatic dysfunction, then maybe we can go to include DSD in the context of more modern or current scientific literature. We can maybe use also somatic dysfunction as a proxy of function. So I'll come back on that concept later on. We can talk also about regional interdependence. We can also see maybe sometime somatic dysfunction as a musculoskeletal risk factor. So that could be also an interesting point to address in research. There are also the biopsychosocial model that can be included into the use of somatic dysfunction in research. And another question, if OMT or manual therapy can have an effect on somatic dysfunction, can in other sense, specific exercise or self-management approach be used in conjuncture with OMT or by itself to treat those somatic dysfunctions? So that's a question that we may ask. And again, if we go into that way, that could give a chance to have, control group and to better understand the role of OMT toward the response of somatic dysfunction in time. There's also the concept of minor musculoskeletal problem and the concept of wellness. So, and that's maybe some point to go from a more biomedical physiophysiological model to a more modern approach. So quickly, those were the nocebo effect that were associated with the concept of somatic dysfunction. I won't go into that, but that's maybe a good reference to keep in mind. And also when we use the mechanism of manual therapy, so we know that somatic dysfunction and OMT, they'll have probably an effect on the tissues and how then on the patient or the people are rating their pain. So we have like both effect on tissue and people are rating. So maybe those option could be a good way at some point to better identify somatic dysfunction. And in research, what we can do later on is to use the TART or the START, like Gary Fryer said on last presentation. So first of all, if we have a patient that comes, we may eliminate red flag. We can start with functional testing and then identify some mobility dysfunction. From there, if there's pain, so the S of the START, we can do some special orthopedic test. At some point, we can go for further imaging or medical investigation. If it's negative, then we can address the TART of the somatic dysfunction in joint play. So is there hypomobility, so restriction or asymmetry? And if that's the case, the choice of OMT will be more around HVLA, MET, FRP, or GOT. And if there's no hypomobility or restriction, then we can address a tissue texture change or tenderness. Then we'll go to a tissue appraisal, and then the choice of OMT will be different, because in research, it's hard. Sometimes we don't see that difference, and it's hard to arrive at a conclusion that OMT is working or not, because we don't know what they specifically treated. So if we go from a new insight, so we go from a more passive to a more active use of the TART principle. So let's say the sensitivity of pain provocation can be done by special tests, but in an active way, it can be about functional movement. Tissue texture change will always be more passive. Asymmetry, again, will be, we can go to an anatomical landmark or statistical posture, but into an active way, we can find that asymmetry also in functional movement, strength endurance, motor control, coordination, or stability. And again, the restriction, so joint play or passive ROM. And if we translate it to a more active approach, then again, functional movement will be there, mobility or motor control, active range of motion, and even active palpation. And tenderness, well, again, will always be more of a passive approach. And the question that we always want to ask is, how do we integrate that in a more biopsychosocial perspective? In which context? So is it about pathology, wellness, or minor risk factor? And to address those, is it only OMT, or we can use a risk factor or exercise? So that's a question that may also arise. And are all OMT equal in clinical and research? I mean, I don't think so, but again, research doesn't always treat, it's like OMT are always on the same page, whatever it is. But again, we may go back to what we said. So there's some patient preference, contraindication, absolute or relative, patient tolerance to manual therapy that should be considered as well, tissue or joint play, so the TART. It must be more evidence-based. And do we apply it to a pathology, like the example of the STRAPS trial? And can we use exercise to, like I said earlier, to objective the role of OMT treatment? Like like if we combine, let's say, FRP with McKenzie exercise, or muscle energy with mobilization exercise, or myofascial release and foam rolling. So can we have any information about this? So it brings back to that, regional interdependence, or that globality that we can address. So I think that's really important when we apply OMM. But again, are we global or we say local? So I mean, the research should specify that when they do. And it brings me back maybe to one of my last slide. So those are the risk factor. It's a new review about risk factor to getting MSK injuries. And one of the things over there is, we got an history of previous injury, physical inactivity, so sedentary behavior. There's also asymmetry over there, statical balance, ankle dorsiflexion, all functional testing, BMI, cardiovascular fitness. And like I mentioned earlier, well, the role of somatic dysfunction can be used as a risk factor for the development of MSK injury. So, I mean, at some point that could be a little bit more useful to understand the role of somatic dysfunction and which OMT to apply. So that's bringing me back to a more, let's say, modern approach to the OMT somatic dysfunction into a global or interdependence paradigm. So the classical approach was most based on an anatomical probabilism and sometimes in vitalism, but modern approach will be more evidence-based. We also include in the modern approach risk factor assessment, questionnaire, functional testing, orthopedic testing, joint play, tissue appraisal for somatic dysfunction. Evidence-based was also choice of imaging and lab test. We use also in a global approach the health span promotion approach, like active lifestyle, psychological status, VO2 max, muscle mass, strength, emotional health, etc. And it's more like patient center, more empowerment and less, dependent about the osteopath. So it creates less dependence, and also it's a shift into the practice, which again at some time was more like a only OMT oriented or passive approach to a more active approach where OMT still have its place, but we have a focus on education, psychological, social context, specific exercise, and general exercise. So that's probably it. So thank you for all your thought. I know it's I don't claim to be right of what I'm saying. It was just a thought about the role of somatic dysfunction in research. So I put some grains. You may not agree, but again, I think we have a lot of discussion over there, and I don't claim to be right.
All right. Well, thank you, Dr. Lalonde, for that wonderful presentation. So just before we open up the floor to everyone for questions and discussions, just a few reminders. First, if you would like to speak during the discussion, please raise your hand emoji, which is located at the bottom of your screen under the reactions menu. We ask that you give a brief introduction, at least the first time, of yourself. And please feel free to turn on your camera when discussing if you would like. And second, when contributing to the discussion, please limit your microphone time to about 3 minutes to allow for time for everyone who wants to participate in the discussion. And that can be in response to somebody else's comments or asking an initial question. We'll provide with a timer to assist you in keeping track of that time. And after everyone has had the opportunity to make comments or ask questions, there may be more time. So we'll keep going until about 3 till. The moderators will be happy to read questions or comments if you prefer to type them into the chat. I know there was one in there before. And so Dr. Truax, if you would like to read your comment, feel free to. Otherwise, I open it up to everybody for the discussion for the episode.
Yeah, thank you. I'll let people read it because I like Jan's response too. But I just wanted to get your opinion. When you talked about somatic dysfunctions and nociceptor stimulation and inflammatory, but I'm more and more convinced, and I wrote this in here, that the underlying physiology of what we call somatic dysfunction or the background is going to be found in exercise physiology. And unfortunately, we think of exercise physiology as exertion, but when we get up from our bed and start walking, we're engaging in exercise physiology, in the fatigue physiology. If somebody gets pneumonia, they got to work harder. And fatigue physiology stimulates sympathetic nociceptors, creates symptoms, but there is no pathology. And if our body self-recovers, then great. But if our body doesn't recover from the fatigue physiology, let's say somebody's deconditioned or they have repetitive movement, then they will have persistent fatigue physiology, which I think perfectly defines somatic dysfunction. And I think that's why exercise can be so effective, since fatigue physiology and exercise physiology intersect with one another. So I just want your thoughts of and I think that a reason why there's discord in understanding, agreements with it, is because we're looking for the pathophysiology. Is it tissue damage? Is it inflammation? But if we start with just muscle fatigue, which affects every human who lives in a gravity-filled world, then that's the fatigue physiology is a common denominator.
Yeah, and thanks for the comment, Rob. I mean, I totally agree. I think, well, again, really humble over there. Since it's not like a clear physiopathological, like I demonstrate, it's more like maybe in functional movement that we can find the let's say the manifestation of the somatic dysfunction at some point. And if we can find it into functional movement, then we can track it back down, either if tissue texture change or whatever target it is, then we can see if the intervention has an effect on the function. And then again, if we keep that altered function in a long time, that can lead to, let's say, diabetes or whatever other health concern. So that's, I guess, a main thing. But the other part is, if we take a look at the STOPS trial for low back pain, again, I think that we can clearly identify maybe for low back pain at some point some patient that will respond better to some type of OMT, and if they do, then what's the underlying somatic dysfunction over there? So I mean, there's some maybe question to be answered over there.
Yeah, hi, this is Jan Pryor. Yeah, I was responding a bit to Rob's comment as well, and reflecting a bit on how I kind of work with students to help them understand somatic dysfunction, and reflect a bit on Nelson's thoughts on it in the textbook Somatic Dysfunction in Osteopathic Family Medicine. In that, somatic dysfunction really is looked at maybe more as a physiologic process. It's the body's best shot at trying to deal with whatever stresses is imposed on it. And again, is a normal response. It's not pathology per se. It might be a response to other pathology that gets established somehow. It might eventually predispose to pathology, but actually it's a healthy response. It's the whole thing, right? The body's always trying to heal itself. So somatic dysfunction is a reflection of that attempt to address those various stressors. And that's why it's so important for us to, if we can eventually work with OMT, but also other things in terms of eliminating stressors, be it a lifestyle issue or a postural thing that is recurrent, that this is something that you can deal with and the somatic dysfunction will eventually resolve. But it's really there as sort of a reflection of a normal, this is your body's best shot at doing the best it can right now. And it's actually a reflection of normal function, is that we get these TART changes, which we call somatic dysfunction.
Yeah, definitely.
Yeah.
Yeah, and I'm more than agreed. And it's definitely the body's reaction to something that it reacts. And again, my thought, and I mean, I'm may be right on this one, but maybe the global outcome of this is, you know, on functional testing, or even, you know, functional movement. So from that, we can derive to identify a specific somatic dysfunction using the TART. So again, from that perspective, I think that it better targets the choice of OMT, it better targets the choice of exercise. And also, if we take the patient holistically, then we can address, you know, those lifestyle that may have an impact on somatic dysfunctions. From that perspective, I think that from research, it's feasible, and it's, I mean, yes, it's a challenge to try.
I just wanted to say one more thing. I think one of the reason I'm sort of passionate, I think about the exercise physiology point, and this comes to you as as a non-American DO.
Yeah.
When somebody comes in with me to pain, I have multiple options to treat that. But if I think of pain as a pathological process, say a torn ligament, a fracture, kidney stone, well, I'm not going to think of an exercise to help with those things. So their pain does not fit with the pathophysiology of what's going on, because their pain is reflective of tissue damage.
Yeah.
And so, but if I can't find tissue damage, well, now what is the underlying physiology? Well, that's probably what I think is that nociceptive stimuli through fatigue, not inflammation, and so manipulation works. The problem, I think, is in the international DOs, when somebody comes to you with pain, you can only treat that with somatic dysfunction or with manipulation of focus. And since many people have a pathological origin, or can have a pathological, OMT somewhat helps. And so you can actually feel frustrated. The DOs international can feel frustrated a bit. But if we distinguish and it says, okay, do they have pain from pathology or discomfort from fatigue? See, pain from pathology will probably generate some fatigue, like severe arthritis of the hip will create fatigue of the low back, and I can treat that. But we can't treat the severe arthritis of the hip. But if they have infection of the hip, that's surgical. So I'm just wondering if the need for equating pain with somatic somatic dysfunction as the causing of pain, which Jan was saying, like, no, it's a normal response. If we step away from somatic dysfunction as treating pain, we have to come up.
Yeah, and I think the pain model, it could be a good option. And like you said, you in the US, you have all the, you know, the best situation to practice full medicine with the osteopathy. So, but we don't. But abroad, most osteopathic are not physician. So the only tools that they have is OMT. And again, we try to have a shift. Let's say when it's you know, infection, or there's, you know, their bone is broken. I mean, we have to refer them to an MD. Okay, so we cannot treat them. So, but maybe afterward when he's in rehab, so that's, you know, another aspect. But when they first came over here, we cannot treat them. So it goes always back to referring back to an MD, or okay, if it's okay, then we'll treat it with OMT. Okay, sorry for the time's up. But again, yeah, very interesting.
Go ahead, Dr. Degenhardt.
Yeah, so several people have brought up that the body's response, normal response to whether that is an activity or to a particular underlying condition, is somatic dysfunction. And we typically are treating somatic dysfunction. That means sometimes we are actually treating and perhaps inhibiting the body's normal response to the underlying phenomenon, whatever that is. And so we kind of are trained in such a way that we inherently see somatic dysfunction negatively, that we have to treat it, resolve it, when it may actually be part of the normal way that the body's trying to deal with it. And we're actually counteracting a body's normal response to whatever that is. So it's an interesting thing to think about. I'm not saying I have any answers, but with the conversation, it seemed like it fit.
Yeah, that's a great perspective. Yeah, it's worth considering, I guess. Yes.
All right,
Especially-
I was gonna say we have time for maybe one more comment. Sorry, go ahead,
Just-
Dr. Jan.
And then again, reflecting on what Dr. Degenhardt just said, and that's why, we'll see somatic dysfunction coming back. Well, of course it's coming back. It's coming back because it's still there for a purpose. It's that the underlying stressors haven't been dealt with. And so then again, you can go down a rabbit hole by looking at it. Well, I keep chasing my tail by, well, these pesky tart findings keep coming back, that what I call somatic dysfunction, and I'm supposed to somehow like slay that dragon. And it's actually the thing I want to embrace and use it to the body's advantage, but figure out, so what are the stressors that I'm missing that keep bringing it back? I think that's it's a tempting way to look at it sometimes.
Yes.
All right. Well, unfortunately, our live discussion time is up. So don't forget that this webinar recording will be placed on the DO-Touch.NET YouTube channel, where we can continue this conversation. Watch your email for an announcement when that recording is available. So thank you again, Dr. Lalonde, for this wonderful presentation. Just a reminder that we do not have a Let's Talk About OMM Research episode in December due to the holiday season. So our next episode of Let's Talk About OMM Research will be an educational webinar that will be on January 23rd of 2025. And our discussant will be Dr. Alan Yee. And his topic will be on post-stroke disability, and he's going to be sharing some preliminary data examining the impact of OMT on post-stroke function and somatic disability severity. So just this is a week later than our normally scheduled Let's Talk About OMM Research episode, as we usually do those on the third Thursday of the month. This one will be on the fourth, which I think is going to be fine with it, the Thursday being early in the year and everything, pushing it back. So hope to see you all then. Thank you all very much for coming. Yes, Dr. Degenhardt, I see your hand up. I do apologize. Sorry.
It's okay. Yeah, so Dr. Yee is a neurologist at the University of California in Davis. He's been an active integrator of manipulative medicine in his specialty practice for years. So I really want to encourage people to attend. Also, Corey, can you just maybe give just begin letting people know about our upcoming annual meeting?
Yes, that is, well, thank you for the reminder. And so our upcoming annual meeting, we did just save the date out this week, but that will be all virtual, and it will be in the first Saturday in April, which is going to be April 5th. And it'll be from 10 a.m. to 2 p.m. U.S. Central Time. So that'll be able to incorporate our European members, as well as not be so early for our West Coast members and such. And so our 2025 annual meeting will be April 5th, and it will be all virtual. And so we did send our initial save the date out. There will be another one going out, and as soon as we have registration open, that will be going out as well. All right. Well, thank you all again for coming today, and we look forward to seeing you all next time.
Thank you.